Hello and welcome to Health Live at Seniors Today. We are delighted to have here with us Dr. Rajiva Gupta, who is from Gurugram. Dr. Gupta is a senior consultant in internal medicine and diabetes with an experience spanning over 4 decades. He did his MBBS from the Maulana Azad Medical College in New Delhi and the MD and an MD from the Dr. Ram Manohar Lohia Hospital also in Delhi. He has done a postgraduate diploma in diabetology from the Johns Hopkins University School of Medicine in the US and a specialist certificate course from the International School of Diabetes. Dr. Gupta currently has consultation practice as his personal clinic, Upchar Wellness in Gurugram, as well as he is attached with the CK Birla Hospitals in Gurugram and Punjabi Bagh in Delhi. Dr. Gupta has been conducting continuing medical programs in the fields of internal medicine with a special focus on diabetes, clinical cardiology, and geriatrics, and has given lectures and conducted certificate courses on various topics in diabetology, cardiology, critical care, geriatrics, and COVID-19. He's attended various national and international symposia, conferences, and workshops in India and across the world. He has been an active researcher, having participated in several national and global clinical trials in the field of diabetes and cardiology. He's a member of various international and national associations of repute. Welcome to Health Live, Dr. Gupta. How have you been?
Thank you, Pradyuman, for the very nice and kind introduction. So I am thankful to Pradyuman for having given me an opportunity to address this august group of people spread across the country. And I would be very happy to share my insights on a very common topic which we face on a day-to-day basis, care of diabetes.
Yeah, thank you.
In the elderly patients.
Thank you very much, Dr. Gupta. So, when we were discussing and we thought, well, we've had many diabetologists in the past, but we said, let's look at a very basic topic about care for diabetes in the elderly. And, one of the things that we try and do is look at various issues and concerns that senior citizens have. And with the vast experience that Dr. Gupta has, it would be only appropriate to have his gain from his experience. And over to you, Dr. Gupta, with your presentation. Those of you who have questions, as always, please put them in the Q&A tab. Do mention your age and your gender so that Dr. Gupta can give you a considered reply. Over to you, Dr. Gupta. So I have my colleague, Firoz, who's going to be helping out with the presentation. And once the presentation is over, then we will come to the questions. Thank you.
Yes, so the topic for today is care of diabetes in the elderly. Next. So let's first define the extent of the problem. It's not clear. The slide is not clear. The slide is not clear.
Yeah, we'll just correct it.
Yeah. So the extent of the problem that people 65 and above, they comprised of 6.8% of the population in 2021. And this is the World Bank data. And the slide is not clear. It's very blurred.
Just give us 1 second. I'm sorry. We'll just get this done. Technology. Sometimes we try our best. Let's go further, Firoz, before. Just 1 second. Let's try and go further before we continue, because if there are some problems, then we'll
Again blurred.
Again blurred. Okay, Feroz, I suggest, can you just stop the sharing of the screen? Let me try and see. Sorry, 1 second. All of you out there, please bear with us. These things happen. Sometimes a simple thing like a presentation just 1 second, sir. 1 second. Uh, Rose, can you do something? I don't know why. It's opening now.
If I can take on my screen and
Feroz, it's again not coming, Feroz.
can I, if, I mean, is it necessary for my face to be shown if I just take it on this?
No, the sharing of the screen and your face and your image is not a thing. Let me just check. Feroz, you locked me out. 1 second. Let me just get the thing.
Yeah, now I think this is okay.
Yeah, so just 1 minute. Just 1 minute. Let me just get my thing in order.
Let it be the full screen. It's full screen is not coming.
Yeah, I'm just trying to see.
So that thing is there, an inverted thing which we click and the entire screen comes.
Yeah.
Yeah. Yeah, so sorry for the interruption. So the topic for today is care of diabetes in the elderly. Now, before moving on, let's define the extent of the problem. In a survey done by World Bank in 2021, people 65 and beyond, they comprised about 6.8% of the total population in India. And out of 30% of people more than 65 have diabetes in India. And this was as per a survey done by A. Jain et al., which was published in one of the medical journals. Why is the number so high? It is predominantly the aging of the overall population is the main driver of increasing prevalence of type 2 diabetes mellitus in the elderly. Next, please. The management of diabetes in the elderly is complex. The reason is that the population, elderly is a very generic word, but within that same age group, there is a diversity of population. At one end, there are people who are very robust and healthy, and at the other extreme are people with frail, multiple comorbid medical conditions, age-related geriatric issues, and the complications of diabetes, which will come subsequently in the presentation. Next. Then there is the differential risk of complications. This is a phenomenon which is many times overlooked by, I would call, the physicians. Previous. Now it depends. Now a person who is, say, 65 or 70 years of age. Next one. Next. There is a differential risk of complications which depends upon when diabetes were diagnosed. Now a person who is 65 or 70 years of age, suppose his diabetes were diagnosed somewhere in his middle age, at the age of 45 or 50 years. Such patients would have a significant prevalence of diabetes related complications concerning the kidneys, nerves, and eyes. And on the contrary, if the diabetes is diagnosed in older age group, these people would have few or no diabetes specific complications. The reason being that the typical microvascular complications which affect the kidneys, nerves, and eyes are dependent upon the duration of diabetes. However, because of the age, the patients who develop diabetes in the older age group, they are at a higher risk for macrovascular. Macrovascular means the complications which pertain to heart, brain, stroke, etc. Next one. The elderly people with diabetes are at very high risk of polypharmacy. Now, polypharmacy, we all know, is a use of multiple drugs because of multiple comorbidities, and it is not necessary the person with diabetes doesn't have anything else. So we see that this presence of polypharmacy is usually defined as using more than 5 drugs. Functional disabilities, as we said, that the patients may not be in the best of their functional ability. Cognitive impairment, it all depends with aging. Somebody may develop a minor degree of cognitive impairment, no cognitive impairment, or a serious cognitive impairment. Depression due to multiple reasons. Urinary incontinence. Elderly patients are more prone to falls with diabetes, and they may be having persistent pain. So all these factors which have a bearing on the choice of medical therapy and how to proceed or how intense the treatment should be. Next. Next, please. What are the treatment goals in the elderly? The foremost is we have to avoid symptoms of hyperglycemia. Hyperglycemia is high blood sugar. Now, how do we define high blood sugar? That will come because we'll have to define the targets of blood sugar. And hypoglycemia. Hypoglycemia is low blood sugar, which is defined as a blood sugar which is less than 70 milligram per deciliter. Then we have to prevent acute complications, mainly they are the infections, and chronic diabetes related complications like the complications with the nerves, kidneys, eyes, heart, and brain. And foremost, you have to optimize the health related quality of life. All the treatment goals and regimens should be individualized, which are based on the preference of the patient. The risk of hypoglycemia. Now, what are the determinants or the risk factors for hypoglycemia in elderly people with diabetes will come shortly. The life expectancy depends upon the age of the patient at that point of time or what illnesses the person is having. Comorbidities, complications, cognitive function, adherence and motivation, the duration of the disease, the resources available, and the support system which an individual has. So all these factors have to be taken into consideration when we define the treatment goals in terms of the values of blood glucose. Next. So avoiding hypoglycemia or low blood sugar is the cornerstone or the fundamental objective of treatment of diabetes. Elderly people are more vulnerable to hypoglycemia, and avoidance is an important consideration in establishing blood sugar goals and choosing a therapeutic regimen. Certain oral drugs, as well as all types of insulin, have a propensity to cause hypoglycemia, and should be used with caution. Elderly who begin with a dietary or an exercise program and who are at or near the goals may need a reduction in the dose of medicines to prevent hypoglycemia. Because it's paradoxical. At one place, we advise the person with diabetes to have a restriction in diet or modification of the diet and encourage physical activity. So initially, the blood sugars may be high, but as the effects of the lifestyle modification start taking place and start showing their effect, the blood sugars may go down. So here we may have to de-escalate or de-intensify the treatment. Next, please. We were talking of hypoglycemia all this time. So what are the risk factors for hypoglycemia? Poor cognitive function, compromised kidney function. This is one of the most common reasons why a person goes into hypoglycemia. In fact, in which the many patients come to us and they tell that my blood sugar is fluctuating a lot and I tend to go into low sugars and start sweating at odd times of the day. And once we investigate, we find that their kidney function is declining or compromised. Compromised liver function, therapy with insulin or sulfonylureas. Sulfonylureas, we all know, are the drugs like glimepiride or glycoside. Strict glucose control. So when the person is put on a very tight glucose control, the chances of going to low sugar become high. Previous episodes of hypoglycemia. They say that hypoglycemia begets hypoglycemia. A person who has had an episode of hypoglycemia once is always more prone to develop it subsequently. Then after discharge from the hospital, suppose the patient is admitted in the hospital. So in the hospital, the illness is there, and because of the illness also, there is a contributing factor to the raised blood sugars. Once the illness gets resolved, the person gets back to the home. And if you continue the same treatment with the same intensity, the chances of hypoglycemia become very high. Then there's a thing called blunted counter-regulatory response. So what the nature has done is that once the blood sugar starts falling, then there's a cascade of chemical reactions or hormonal changes inside the body which try to restore the blood sugar to normal. Plus, the person who starts developing low blood sugar, there is a perception. They may be feeling of weakness or palpitations. So many times in the elderly, these regulatory responses are blunted, and the person may not be able to perceive the incoming or the subsequent development of hypoglycemia. And by the time it comes into notice, the person may have become very sick. Polypharmacy means use of more than or equal to 5 drugs. Now we don't know if the person is taking so many drugs, then which drug is having interaction with the diabetes regimen. Depression, because depression would somewhere would contribute to erratic meals, failure to do exercise, poor nutrition. Now, if the medicine is going on and the nutritional intake is not adequate, such patients may go into hypoglycemia. Heart failure is another risk factor or predisposing factor for hypoglycemia. Next one. So there has to be a balance between hyperglycemia and hypoglycemia, which means that we want a maximal glycemic control or glucose control with a focus on avoidance of hypoglycemia and minimizing hyperglycemia. Now, why is hyperglycemia management important? Because first, that is a hallmark of diabetes. If you do not correct hyperglycemia, then the person will end up into dehydration or electrolyte imbalance, urinary incontinence, because when the blood sugar start rising, there may be increased amount of urination. Because of sheer hyperglycemia, there may be fatigue, lethargy, visual impairment, cognitive impairment. The person is put to increased risk of infections, poor wound healings, and functional decline, and the risk of falling. So all these are the consequences of uncontrolled hyperglycemia. Why do we have to minimize hypoglycemia? Because hypoglycemia may cause falls, and subsequently the person may suffer fracture, which again becomes detrimental to the life. There is confusion, barrier to control. A person who develops hypoglycemia in one episode, he becomes very, 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 very apprehensive. No, I don't want to take insulin or I don't want to take medicines. It is called low sugar. Treatment burden. The person may start thinking that why the hell it is? Why should I take treatment? Because it becomes too much of a burden to keep on thinking every time how much to exercise, what to eat, take medicines regularly, what to make less, what to increase. Adverse cardiac events. Patients who are already having a cardiac problem, if they develop hypoglycemia, they may develop what is called arrhythmias or disturbances in the rhythm of the heart. Repeated episodes of hypoglycemia, they result in cognitive impairment because each time hypoglycemia happens, the brain is deprived of the sole source of nutrition, which is the glucose. And such people, if they keep on developing repeated episodes, they may develop a prolonged or a persistent cognitive impairment. And especially if the hypoglycemia is repeated or if the episode of hypoglycemia is prolonged for a long period of time. Next, please. Next, please. The symptoms of hypoglycemia vary in the elderly. So there are essentially two types of symptoms of hypoglycemia. One is the brain manifestations, which result from the deprivation of the nutrient or the glucose in the brain. So that is manifest as dizziness, weakness, delirium. Delirium is abnormal behavior or confusion. Compared with the adrenergic manifestations. Adrenergic manifestations are the ones which are a consequence of the release of adrenaline or the catecholamines or the stress hormones, and which are tremors, sweating, and brain symptoms may result in delayed recognition of hypoglycemia. Why? Because they may be missed or misconstrued as a primary neurological problem. It may be a stroke or leading to underreporting or delay in seeking medical attention. Or maybe just somebody might say the person is behaving abnormally. It is just some sort of a abnormal behavior, rather than thinking that the hypoglycemia may be the underlying cause for such a behavior. Next. So there is an interaction between diabetes and the geriatric syndromes. The geriatric syndromes are basically the multiple problems which a person, when he enters into elderly age group, may face or may not face, but they are, as I mentioned earlier, incontinence, frailty, mental health problems like dementia, depression, persistent pain, decreased functional status. So diabetes affects both physical and mental health, leading to the development of geriatric syndromes. The effects of geriatric syndromes may contribute to the worsening of diabetes control, initiating a vicious cycle. So as you can see in this slide, so diabetes mellitus is there. It may cause mental health problems, dementia, depression. It can cause physical health problems, disability and frailty. And once these occur, then there is a further worsening of diabetes control, and we'll end up into a trap of diabetes mellitus, creating problems, physical and mental, worsening diabetes control, and this cycle goes on. So therefore, an optimum balanced approach to the treatment of diabetes in the elderly is very important. Next one. So having said that, now a balance between hyperglycemia and hypoglycemia, how do we determine the blood sugar goals? So basically, as I said, that the diversity of population in the elderly people is noticeable. So for healthy people, functional status is good. There's no comorbidity, and the diabetes is of short duration. There, one can go in for a stringent goals, which means an HbA1c of around 6.5 to 7.5%. Conversely, if there is hypoglycemia, a shorter life expectancy, comorbidities, geriatric syndromes, falls and fractures, disabilities, functional impairment, multiple drugs. In these people, we can have flexible goals with HbA1c ranging from 7.6 to 8.5. So it depends. If we start treating the patient and we are able to achieve a particular HbA1c level, and if you find that if you want to push it further, so that has to be done very cautiously, taking into consideration and very strictly monitoring that the person doesn't go into hypoglycemia. So these are flexible goals. As such, the goals in elderly people with diabetes have to be individualized based on all the factors which I mentioned earlier. Next one. Next one, please. So coming to the treatment, the lifestyle modification is the cornerstone of management of diabetes. It consists of counseling on nutrition, counseling on physical activity, and weight reduction if required through diet, exercise, and behavioral modification. So there have been a lot of trials and landmark trials which have been published to support or as an evidence for the benefits of lifestyle modification. There was a trial which was it's a landmark trial and which was done somewhere in 2002, where it showed that the oldest age group, that was called the Diabetes Prevention Program, so DPP. So the oldest age group in the diabetes prevention program, those people more than 60 years of age at the beginning, had the greatest improvement in glucose control, which were related to a better adherence to the lifestyle program. And what was the lifestyle program? It was a behavioral modification program aimed at a low-fat diet and exercise for about 150 minutes per week, compared with the younger age groups, suggesting that older persons can respond well to lifestyle programs. So whenever we say, it's very commonly said that the treatment of diabetes is 70% lifestyle and 30% medications. And as such, if you do not follow this lifestyle, then the choice left for the doctor are very limited. Just go on escalating the drugs with the attendant side effects of the drug therapy. Next one. Next one, please. There was another trial which was done recently. 100 elderly people, mean age approximately 72 years, who were on a stable drug therapy for the previous 6 months. And they were randomly assigned to an intensive lifestyle intervention, which was diet and exercise to achieve a 10% reduction in the weight during 6 months, followed by a maintenance phase, which included monthly educational group sessions. And after 1 year, there was a mean difference of 0.9% in HbA1c and 8.1 kg reduction in the body weight. And they were greater in the intensive lifestyle group. However, this came at a cost of more episodes of hypoglycemia, which we defined as less than 70 milligram per deciliter, than those in the control group. So this reiterates and enforces our statement earlier that we have to consider reduction in glucose during therapy prior to an intensive lifestyle intervention. So again, what is required is a very close observation of the not of the patient's prescription or the drugs, but the entire lifestyle, how the patient feels. On every visit, we should ask, how are you feeling? Have you had any adverse episode of hypoglycemia? Are you adherent in taking treatment? So at each visit, these things should be looked into. Next one. What are the benefits of exercise in elderly with diabetes? Numerous benefits. It maintains physical function. It reduces cardiac risk. It improves insulin sensitivity, which means that especially in type 2 diabetes, there is already a circulating insulin, vis-a-vis type 1 diabetes, where there is a total deficiency of insulin. So once you exercise, they say exercise actually acts like insulin. The work of insulin is to shift the glucose from the blood to the muscles, and the same thing is done by exercise. It improves arthritis pain. Many people with diabetes in that age group, they may have osteoarthritis. It reduces falls, reduces depression. In fact, in one of the recent articles, it was said that an exercise regime, it acts faster in alleviating anxiety as well as depression. It increases strength and balance, so further preventing falls. It enhances the quality of life and improves survival. So there are myriad benefits of exercise, especially in the elderly with diabetes. Next one. Next one, please. So we should encourage, the physician should encourage the patients to be as active as their functional status allows. Again, we have to titrate it. So functionally independent adults should be encouraged to perform at least 30 minutes of moderate intensity aerobic activity, for example, brisk walking, as well as resistance oblique weight training at least 5 days per week. Now, this weight training was not added earlier. Like when I tell my patients, they said, "Abhi stage mein kya karenge? Is stage mein dumbbell uthayenge hum, exercise karenge ye wali." We have to encourage them. We have to be with them, support them. Yes, you should try that. At least start with say 1 kg or 2 kg under supervision, because that would add to your muscle mass. It will prevent the age-related muscle loss. It will improve insulin sensitivity and give an overall sense of well-being. People who are sedentary should be advised to increase gradually their activity from current levels. Something like they can walk inside the room for 5 minutes, 1 to 3 times a day, and build it progressively to the daily exercise goal. Again, this is had to be individualized depending on the functional capacity of that particular individual. Next one, please. Next one. So many times a question is put, do we need to get an exercise testing like a treadmill test or a stress echocardiogram prior to starting an exercise regime? Not indicated for most asymptomatic adults prior to initiating moderate physical activity, unless they already have a cardiac problem or they are at high risk for heart disease on the basis of multiple risk factors. So multiple risk factors would be presence of hypertension, presence of smoking, very high cholesterol levels, family history of premature cardiac disease, etc. Patients with deconditioning. So deconditioning means that the persons who have not exercised or not moved for a long period of time. Patients with deconditioning who are at risk for falls should be referred to a physiotherapist for muscle strengthening and balance training in a safe environment. So before sending him for a structured exercise regime, some effort has to be put by the physiotherapist so that the person is conditioned in a gradual manner and take on the exercise regime. Next one, please. Now, after talking about the lifestyle the component, the exercise component of lifestyle, let's talk about the dietary considerations. Nutrition management is an integral component of diabetes management. And a trial showed that patients in the intervention group had significantly greater improvements in glucose parameters. Next one. As with exercise, as with drugs, as with goals, nutrition therapy also has to be tailored to the individual, because there are many challenges which are practical and real. Altered taste perception, coexisting illnesses. Now, suppose somebody has got a cardiac problem or a renal problem, kidney problem, then the person may require fluid restriction, liquid restriction, or low salt. Compromised dentition. Now, again, the choice of food items would be limited. Altered digestive function. So, there is a thing called gastroparesis, which means that as such with advancing age plus diabetes, the emptying time of the stomach becomes less. So that would pose a challenge in the type of food. Lack of food supplies and preparation capabilities. The same resources may not be available to everybody. There may not be supplies, and there may not be the facilities for cooking of food. Memory decline leading on to skipped meals. This is very common, especially people if they do not have support systems in the home, then the meals may be skipped and the person may go into hypoglycemia, or even forget medicine and may go into hyperglycemia. We have to take care that we have to avoid a complex dietary regime, and the regime should be tailored to the preferences of the patient, and it should be as simple as possible. In this situation, it is always better to take the advice of a certified diabetes educator or a nutritional counselor. Next one, please. People with overweight or obesity and high functional status may benefit from caloric restriction and an increase in physical activity with the weight loss goal of approximately 5 to 7% over the next 6 months. Older patients who are not overweight or obese require a diet with preferred food items to prevent weight loss. Now, it's paradoxical. People who are overweight should attempt to lose weight, but not too much. And who are not overweight, we don't want them to lose their weight further, because weight loss is associated with increased morbidity and mortality. Next one. So we've talked about the exercise, physical activity, diet. Mental health issues are also very important. Assessment for mild cognitive impairment or dementia at the initial evaluation, and thereafter annual or as appropriate for the individual patient is important. The identification is critical because we have to assess whether the patient is capable enough to self-manage diabetes treatment. Because diabetes treatment is finally for such a long-term disease, which is there 24/7, you have to think about it. There has to be capability of managing that. So that should be assessed, and whether the person is capable of it, doing it or not. Cognitive function and the possibility of depression should be assessed in the presence of, especially when you find that the person not adhering. Now, why is he not adhering? People say, so when I ask them, क्यों नहीं आप walk करते? आलस आ जाता है. आलस क्यों आ जाता है? Some sort of a stress is this. Maybe mild depressive symptom may be there. Frequent episodes of hypoglycemia or extreme glucose fluctuations. Again, if you are not stable emotionally, then you don't adhere to the timings of the meals and may go into a roller coaster of hypo and hyper. And there is deterioration of glucose control without obvious explanation. So we always have to address these issues, because it is not that something is we find that the glucose level is going high. So one thing is that as a knee-jerk reaction, you just start increasing the dose of insulin or adding medicines. But the root cause lies somewhere else. So this assessment is important during the management of the patient. Next one. Reduction of cardiovascular risk. As in our initial slide, we noticed that the elderly people with diabetes are at a very high risk of cardiovascular events, which means heart attack, heart failure. These people, the elderly people with diabetes, are more likely to derive greater reduction in morbidity and mortality from cardiovascular risk reduction by means of high blood pressure control and the cholesterol lowering with statin therapy than from the tight control of blood sugar. So this is another fallacy, because a person with diabetes has to be educated that the aim of diabetes, because the most common complication of diabetes is a cardiac problem, which I think everybody knows today. Pushing the person to very tight sugar control doesn't give excessive too much benefit. On the contrary, it may be harmful. However, the benefit which is derived from control of blood pressure in the target ranges and with the control of cholesterol, the statins, is far more effective. Next one. Then the diabetes complications. So we should be screening for the diabetes complications. I have specifically included the retinopathy, which means the complication affecting the eyes and the foot problems. Kidney disease as such, I mean, it has to be screened by means of the kidney function test and if there is any increased excretion of albumin in the urine, because in that case, it will be managed by the primary caretaker, primary healthcare provider, or depending on the situation, the person may have to be referred to a nephrologist. So talking about the diabetes complications, so these complications which impair the functional capacity of the person, they are important. For example, retinopathy and foot problems. They should be identified and treated promptly. Let's talk about retinopathy. The prevalence of retinopathy increases progressively with increasing duration of diabetes. That's why we said in the earlier slides that persons who develop diabetes earlier in the middle age and when they enter in the elderly age group, the chances of retinopathy are higher because they have been having diabetes for a longer duration. Regular eye examinations are extremely important. Why? Because poor vision can lead to social isolation, increased risk of accidents, falls, impaired ability to measure blood glucose. See, they are so real problems. They have to be looked into. Our elderly people, they need support. They need assistance in these things. A complete ophthalmological examination should be performed by a qualified ophthalmologist at the time of diagnosis and at least every year thereafter. The purpose is also to screen for cataracts and glaucoma, because cataracts and glaucoma are also twice as common in people with diabetes than otherwise. Next one. Foot problems. Foot problems is an unfortunate important cause of morbidity and a much higher risk in older patients. Both poor circulation, which is called peripheral arterial disease, and neuropathy, contribute to the foot lesions, what they commonly called in the hospital as diabetic foot. Any ulcer on a wound which is not healing, diabetic foot. Prevalence of diabetic neuropathy in patients with type 2 diabetes is more than 50% in the elderly, and more than is such a clinically useful test that more than 30% of older patients with diabetes cannot see or reach their feet, and they may therefore be unable to perform routine foot inspection. So it's very easy for me to say, आप अपना पैर देखा कीजिए, उसका examine कीजिए. I think that is my duty, and instruct the person or the family members to at least see the foot of the person, whether it is dry or not, whether there are cracks, whether there is any callosity. So that's important. Next one. It is recommended that elderly have their feet examined at every visit. So, as we say, the person comes to me for follow-up. So you have to see his vital function in the form of the blood pressure, blood sugar, if he already has the chart, or we measure blood sugar. See the foot examination, detailed history of the previous visit. So that assessment assesses the patient's ability to see and reach her feet, and inquiry about other family members or friends who could be trained to do routine foot inspections. So you should always emphasize that the elderly person with diabetes should always be accompanied by a family member, because the role of family in the care of patients with diabetes is of paramount importance. Visits to a podiatrist on a regular basis should be considered if feasible, and also availability of this service. A detailed neurological examination and assessment for circulation in the limbs should be performed at least every year. It is also important that prophylactic advice on foot care be given to any patient whose feet are at high risk. Feet are at high risk. How do we assess? So there is a test called sensation test. So there is a tuning fork test, and then there is what is called a monofilament. So we ask the patient to sit on the chair or lie down on the bed, go to his sole, side of the sole, use that filament, try to prick it, and ask whether the person feels it or not. So that is a very useful, very simple clinical test to detect neuropathy. Next one. So we have talked about the lifestyle, which included lifestyle, the targets, the hypoglycemia, hyperglycemia, exercise, nutrition, mental health issues, screening for complications. Now let's come to the drug therapy. I'll not go into very much details of drug therapy, but probably that would be the domain of the treating doctor. But certain principles of drug therapy, I think we all ought to know. The drug therapy, they match the complexity of the treatment regimen to the self-management ability. So we have been reiterating it. We have been iterating it again and again, that it has to be individualized. See whether the patient can manage that regime or not. Over treatment of diabetes is common. Sugar बढ़ी हुई है, चलो ये दवाई बढ़ा दो, ये सुबह ले ली, रात को ले लो ये. It should be avoided. And the principle is a very old principle: start low and go slow. There is no hurry. We have to assure. Now the patients or the family members, they get upset. Sugar 200 आ रही, 250 आ रही है. ठीक है, कोई बात नहीं. Let's give time. Let's find out why it is high. Whether there is any problem in adherence, or whether there is a problem in the nutrition or exercise. So try to identify the factors, or whether there is ongoing stress. So those factors should be identified and addressed. Oral and injectable drugs with low risk of hypoglycemia are preferred. Next one. Many
Sorry, doctor, we're running a little.
People struggle to maintain the frequent blood glucose testing and insulin injection regimens they previously followed, as they develop medical conditions that may impair their ability to follow their regimen safely. So this is here lies the importance of a simple regime. If you just, especially when people are on multiple doses of insulin, so there that struggle comes, that you have to check blood sugar so frequently. But then again, we have to make the lives of our patients simpler. If once it is under control, maybe initially for a few days we may check that. Then when we identify, okay, make a chart, show to the doctor, and we identify which sugars are coming high. चलो इससे पहले वाले ये check कर लो आप. So make it simplified rather than going in for 4 or 5 times a check. We may make it twice a day, and thereafter, once it gets stabilized, make it less frequently. Not doing it daily, taking alternate day or weekly, depending on the control the person has been able to achieve. Pill dosing dispenser, they are available nowadays in all the stores. They may improve adherence. So there, the person with diabetes can keep the medicines himself or herself. or the family members may assist in helping. Okay, morning में ये लेना है, Monday Tuesday को ऐसे लेना है, ये मतलब morning में ये लेना, दोपहर को ये लेना, शाम को ये लेना. Family members or caregivers may be required to help administer medication, as I said earlier. Cost may be important on account of, as there tend to be many medications. So somewhere it depends. I mean, that is best left to the interaction between the treating doctor and the patient. Because with the advancing technology, with the available pharmacological options, drug options, the treatment of diabetes has skyrocketed. What used to be a tablet, which our patient used to say just cost, say, 1 rupee or 2 rupees, the tablets are costing now. I mean, you'll be surprised to know there is a new tablet which is costing almost 300 rupees per day. So all these factors have to be taken into consideration, whether that increasing cost really justifies the benefit of that particular drug, whether it really the benefit would be there, or whether the same benefit could be accrued by using more economical drugs. So these factors have to be discussed, and it's always good to be transparent. Like suppose I personally, we always give an option. Suppose there is option A and option B. Then tell the pros and cons. Okay, this is the benefits of this. This is the benefits of B. But the caveat is that this medicine costs X amount of money, and this costs the Y amount of money. So cost may be an important consideration, and especially the patient are already on multiple drugs. So it mounts. Already there are said medicine. There may be medicine for heart, for kidneys, and then on top of that, the medicines for diabetes, which are very expensive. So they have to be taken into consideration. Next one.
Doctor, we're running a little short of time. We are at 5:45 already. Can we just? Because
we'll rush up. We'll just. So insulin therapy is has to be used in where there is marked symptoms like weight loss, and one doesn't have to be fearful of it if it is used judiciously. But we have to see whether the patient can manage the diabetes and the insulin on their own. And once one may have heard of Lantus, so a single dose of bedtime or a morning time insulin usually is safe and without too much of hypoglycemia. Next one. Polypharmacy and de-intensification. We already said that the use of multiple drugs is common, and we should review the list of medicines on each visit. Avoid over-treatment. Once the patient has reached the glycemic goals, the blood sugar goals, then one may attempt to de-escalate or reduce the number of drugs, provided the A1C level is maintained. Next one. Monitor of glycemic control. It is by means of HbA1c every 3 months or 6 months if the person is stable. And the self-monitoring blood glucose with the help of a glucometer is also helpful, especially in patients who are on insulin. Next one. Blood glucose monitoring. As we said, it is ideal that the patient should be using blood glucose monitors, depending on, and the frequency may be determined the level of control, and especially if the persons are on medicine which cause hypoglycemia or who are taking insulin. But patients whose blood sugar is very well controlled or just on nutritional or exercise therapy, one may be doing it very infrequently. If the HbA1c is target. Next one. Next one. This is a lot of, it is in vogue nowadays, the continuous glucose monitoring. So when available and affordable, it can be used to patients who are on multiple doses of insulin or who tend to go into hypo and hyperglycemia, who have got very marked prevalence of blood sugar fluctuations. So we know that there are patches which are applied on the upper arm, which measure the sugar level within the below the skin in the interstitial tissue every 5 to 15 minutes. And the data can be read and it can guide us to tailoring the therapy for the individual. Next one. So I'll conclude the talk by just giving a few points. Elderly people with diabetes are a heterogeneous population, ranging from fit and healthy to frail with many comorbidities and functional disabilities, making the management complex. They require individualized goals based on multiple factors as already enumerated. Avoidance of hypoglycemia is an important consideration. Individualized counseling regarding lifestyle modification, including diet and exercise and mental health issues. Next one. Next one, please. Complications that impair functional capacity should be identified and treated promptly. De-intensification of treatment should be done if feasible. And if glucose targets cannot be easily achieved, so this is very important. The most appropriate course may be to modify the glycemic target rather than to intensify the treatment. Because if you do the latter, you would be pushing the person into more side effects, especially hypoglycemia. Thank you.
Thank you very much for an excellent presentation, a very detailed presentation. And, in fact, I also did not really look at the time and just forgot about just 1 second. Let's turn off the. All right, Doctor, quite a few questions have come in. Do we have some time, or shall we look at having you?
We have time. We have around 7 or 8 minutes.
Have you come here once again? So we have a question from Katie Dadanchi, who asks, Doctor, is diabetes hereditary? If one grandparent had diabetes, will her children and grandchildren get diabetes too? If so, what precaution can be taken?
So yes, so diabetes runs in the family. So the most important thing of prevention of diabetes in the family members or the offsprings is to encourage them to lead a healthy lifestyle right from the beginning. Prevention of weight gain, adherence to exercise, and having a healthy eating behavior. So once that is there, the chances of development of diabetes become much less.
Right. Thank you, doctor. And she has another question. Can we replace sugar with jaggery or honey in our meals and our daily cups of tea and coffee?
So see, the glycemic and you can replace, but it should not be a replacement, because at the end of they're also having calories. It is not that jaggery or sugar or honey doesn't have calories, but then in a very modest amount. I don't remember the exact. I mean, how much amount how much calories are there in a particular unit. But they can at times, occasionally they may be used as a substitute, but not as a routine. I would not suggest to be used as a routine.
Doctor, there's a question from Marjorie Fernandez, who asks, what about non-allopathic approaches to treatment of diabetes? She says she's heard of some herbal capsules as alternatives which can ultimately help in becoming diabetes free.
So see, this is a very difficult question to answer, because I go by what I'm trained in, what I read, and the evidence or the literature which is available to me. So, and as such, our medical council doesn't allow us to do cross pathy. So it will be very difficult for me to comment upon that.
Right, absolutely. Doctor, there are quite a few questions that have come in, a few specific which I'm not taking right now, but there is one person, an anonymous attendee, who asks whether is a reversal of diabetes possible.
Yeah, so there's a lot of talk going on about reversal. Now we have to see the definition. So there is what reversal means, that the diabetes does not exist. It ceases to exist. There is a thing called remission. The correct word is remission of diabetes, which means, yes, you do not require medication, but the diabetes state continues. So when is remission possible? Remission is defined as an HbA1c of less than 6.5%, which is non-diabetic range, without the use of medication for at least 3 months. Now, so this is possible, yes, where there is a shorter duration of diabetes, less than 5 years. And if the patients are able to adhere to a very strict diet regime, weight control, exercise, and if they're able to maintain that, that would be called remission of diabetes. But that healthy behavior has to continue. So it is not something to celebrate. Okay, it's good. I mean, one is able to achieve a reduction in doses and maybe eliminate all the doses, but it is not called reversal. So the primary importance is that once a person with diabetes comes, he should get his blood sugar under control. That should be the first step. Adhere to a healthy lifestyle, and thereafter think about remission.
Doctor, thank you very much. There are quite a few questions that have come in which we are not able to take right now because some of them are specific, and we will have them sent to you, doctor, if you don't mind, so that you could perhaps give a response to them. And exceedingly detailed presentation. We've taken almost 50 minutes today of course, the first 5 minutes was slightly tricky because of the tech issues which were there. But thank you very much, Dr. Gupta, for this presentation. It was very good and very informative. And just the fact that you spoke from your experience of over 4 decades was fantastic for all of us here at Seniors Today. Thank you very much. Have a pleasant weekend, and we will be back once again next Saturday at 5 p.m. That is next Saturday, 20th at 5 p.m. On the 15th or the 16th, perhaps in the evening, our next issue of Seniors Today magazine will also be published, and you can have a look at it on our website, that is seniorstoday.in. Those of you who follow Seniors Today are aware that we have some fantastic content on the website. All of it is, as you know, available free of cost. Next week, that is 17th, we are also starting our 11th season of Seniors Have Talent. Seniors Have Talent season 11 starts on Wednesday the 17th. And apart from that, we have a host of events that happen every evening. And some of them are in the morning as well. Thank you very much. Once again, Dr. Gupta, thank you very much.
Well, I forgot to mention that I wrote a book on stress and diabetes. I wrote a book on stress and diabetes.
It, because so there's an amazing book which Dr. Gupta has just recently published, which is called Stress and Diabetes. And what we'll do is, with the takeaways that are carried on Monday, we will carry a picture of the book, as well as a link to where you can get it from. That is a book called Stress and Diabetes, which Dr. Gupta has published. And I've seen the cover, I've seen some of the content.
The underappreciated connection.
The underappreciated connection. Very well said. Thank you very much, Dr. Gupta, for this presentation. And thank you very much, all of you. And have a great weekend. Bye-bye.